So abstract 3200 describing the in-class transition from parenteral bortezomib to oral ixazomib is a really interesting study, and I'm glad to be part of it. And understanding the fact that the majority of patients, whether or not they're transplant eligible or ineligible in myeloma in the US, receive some regimen like VRD up front. Most patients often transition, whether it's pre-transplant, post-transplant, or with no transplant, to a lenalidomide alone or a lenalidomide and dex-based maintenance strategy. And one of the things that we've come to realize is that continual therapy is better. And for some people, we strive to give them an or triplet option, but people often don't want to continue parenteral drugs and like the ease of continuing all orals. The benefit of the approach that we talk about here is we allow them to continue on that triplet, the big combination of a steroid, a proteasome inhibitor, and immunomodulatory agent, by transitioning from the classic VRD onto an IRD-based regimen, ixazomib-lenalidomide-dexamethasone. And this provides for many patients a deepening of response, and it's actually a well-controlled regimen. So the ability here is that we know some patients are likely to have worse outcomes with only giving them lenalidomide alone as a maintenance strategy, where here we can transition them from their VRD induction to an IRD long-term therapy, achieve deeper and deeper responses. And as we understand, deeper responses correlate to more durable responses, and do so without causing undue toxicity. So we feel that this approach may be optimal, especially given the global standpoint of the pandemic, to allow continued multimodality therapy without the need to come back and forth to the clinic for parenteral treatment.